So now we're going to discuss the basics of addiction. At the end of this lesson, I hope you'll be able to describe the pattern of psychoactive drug use and avoid misunderstandings about drug users, understand the causes of addiction and the physiological changes in the addicted brain, and distinguish between physical and the psychological addictions. So back in the day, we were under the moral model, which basically said that if you had an addiction, you were just making bad choices. You were an immoral person. You decided to do this. If you could just start going to church more and make better decisions, then, you would be all good. And then, of course, research comes along that says, that we are now under the medical model. And Dr. Nora Volkow of NIDA actually has some great videos on YouTube that you can watch that she talks about this kind of thing where, there are chemical changes in the brain that make it difficult for the person to stop using. Not impossible, but difficult. And so, unfortunately, a lot of people have brought forward this idea that it's still a moral problem. And they don't recognize that it's a medical issue. It's a disease. And it is a lifestyle disease. We choose to do these things that lead to the addiction. Just like with diabetes, it's type 2 is a lifestyle disease. You choose to eat these types of foods and then you develop diabetes. And then once you develop it, it's there and you have to manage it. It's the same thing with addiction. Once you develop it, it's there and you have to manage it. But these thought patterns have been brought forward. And so some people still believe that it's easy to recognize a drug user, or that using drugs once and it means you're addicted, or people who are addicted are hopeless and they can't be helped to stop using, or heroin's the most addictive drug, or you can always stop using drugs before they become a problem. I want to offer a new perspective on this. We know that most drug users are experimenters, and they're not easily distinguished from anybody else. And not everybody who uses drugs becomes addicted. And I'll discuss this in more detail during this unit. But drug addiction counseling does work. A lot of drug users stop using drugs on their own. And we know counseling works because they've done research studies where people entered voluntarily and people were mandated to come to treatment, and the outcomes were just as good for those that were mandated as those who volunteered. So you don't have to want to come to treatment or have to want to make a change in order for treatment to be successful. The idea behind this is they showed up, they got the information, and maybe that pushed them along that scale of not wanting to quit into thinking about it and then saying, yeah, I think I should change, and then making those changes in their lives just because they showed up to treatment. So treatment does work, and people do stop on their own. And we know that tobacco is more addictive than heroin. And we know that addiction creeps up on us slowly. It's not something that just grabs us the first time that we use and then we're like, oh, I'm addicted. No, that's not how it works. Even though it feels that way for some people, that's not how addiction works. There's a scale. We start out in abstinence and then we work our way up to experimentation. We try it for the first time. We try it in different amounts, different frequencies, different routes of administration, and then we move into social use. And this is where we're trying it with different people in different environments. And then after a while, we get used to it. We know how it affects us. And then we move into habitual use. So every day I'm coming home. At the end of the day, I just crack open that beer and I'm drinking it and so on and so forth. And then after a while, that one beer starts to not cut it. And then we start using 2. And then it turns into 4. And then it turns into 6. And now we're drinking a 6-pack every day. And we've moved into the next stage, which is abusive levels. And then it doesn't take very long once you start abusing the substance to move into addiction from that point. But it didn't creep up on you. And we often miss it. We don't know it until it's too late. And while a lot of experimenters stop without developing the problems, not everybody's that fortunate. So I know you've seen this slide before, but just remember that psychoactive drugs alter the user's mood. When psychoactive drugs enter the user's body, they change the user's mood. So for example, they might become more confident in themselves. They might seem happier or more enthusiastic or sexually aroused or even calmer, depending on the drug. And we know it changes our thoughts or our cognition. A lot of users perceive things differently when they take drugs. And while they may understand clearly that, sharing needles is going to put them at risk, their judgment's going to dissipate when they're under the influence of that drug. And then, of course, our mood and our cognitions, if they're changed, it's going to change our behavior. The way that a person acts under the effects of drugs is noticeably different. They may be more willing to take risks and be more sociable or maybe even more withdrawn. So this slide demonstrates the proportionate kinds of users among those who use drugs. The vast majority of drug users are people who only experiment with drugs, and they use them infrequently based on opportunity and availability. And many of them can and will cease using drugs on their own free will, and they won't really go on to more intensive patterns of drug use. Some individuals are going to use drugs to help them achieve something, like staying awake or killing pain, and we call those purposive users. And then as the drug becomes more intensive and more regular, it becomes a bigger feature of a drug user's life, and tolerance emerges along with intensive drug use consequences like relationship, financial, or employment-related consequences. And the proportion of drug users who ultimately become addicted is influenced by a lot of different factors, and not everybody who uses a drug is ultimately going to become addicted. So on this slide, you're going to see the estimated fraction of drug users who have become addicted. The risk of addiction is different for the different drugs. And as you can see, the different spikes have different heights, and higher spikes imply higher proportions for those who have ever used the drug that become addicted. So tobacco has the highest ratio, 1 out of 3. So 1 out of every 3 who have ever smoked tobacco become addicted. While for heroin, the ratio is between 1 to 4 or 1 to 5. So in other words, between 20 to 25% of those who ever use heroin become addicted. And these proportions are also culturally dependent. The figures quoted by this are for America. And there's going to be differences in different cultures and other environmental settings. Different routes of administration, formulation also has an effect on the risk of addiction. Rapid routes of administration, like injecting or inhaling or smoking, they have higher risks of addiction than the slow routes of administration, like the oral route. And drug formulation also has an effect. Crack cocaine may have higher risks of addiction than cocaine hydrochloride salt. Environmental factors, substance-related factors, individual factors, they all influence the risk of addiction. Just as the experience of use is influenced by the interaction between the drug, the individual, and the environment, so is the risk of addiction. And using drugs is a voluntary and preventable behavior. The key motivators for a person to use drugs are to have fun, or to forget, or to function optimally, or that's purposeful use. Initially, drug users can control their own drug use relatively well. And this initial phase is a good phase in which to focus primary prevention and early intervention programs to prevent drug use from escalating, especially among youth. Many factors influence people when they consider using drugs. And while many individual factors are important, social conditions also have a direct impact on whether people use drugs as well. And those who tend to be impacted most negatively from the drug use tend to come from marginalized segments of the population, and they're going to experience greater stigma or exclusion. So counselors need to be considerate and try to understand more about, where their clients are coming from and what they've experienced in their lives. But drug addiction is not just a lot of drug use. It's more than that. It's the compulsive use of the drug despite the related harms and consequences, including the psychological and physical changes in the brain. The drug controls the user's life. And all drug users believe that when they start to feel that the problems are arising from their drug use, they're going to stop and avoid addiction. What they don't realize is that the changes inside their brain is happening slowly in a way that's difficult to reverse. And what we often see is that they start to make excuses or exceptions for the consequences that happen. Like, oh, that was just a fluke, I just got pulled over because the cop was out to meet their quota that night. I've driven drunk 80 times, and I'm better driving when I'm drunk. And I hear this a lot from these clients. They're making exceptions for each of the consequences that happen because of their substance use. And we don't know much about addiction. There's sufficient information available now to confirm that addiction is not a failing of moral weakness, but rather it's a disease of the brain. Addiction to a substance is the interaction between the neurobiological, the psychological, and the social factors. And unfortunately, this concept is, not commonly understood. And many policymakers and even many healthcare professionals don't know that addiction is a brain disease. So one important role for counselors is to transfer this message to the community and the local authorities to kind of change the attitudes and the approaches toward addiction. Consider individuals who are addicted to drugs as patients with a medical condition who need to be treated. And without treatment, the drug using behavior is beyond their control. Psychoactive substances have effects on perception, emotion, and motivation. And there's evidence from brain imaging studies like magnetic resonance imaging and positron emission tomography, which is an imaging technique that produces a three-dimensional image of the functional processes in the brain. And we know that drugs have direct effects on the brain cell activity because of these. And at the cellular level, drugs exert their effects on neurotransmitters. These are the messengers that relay information between the brain cells. So, what is addiction? Addiction is a chronic relapsing disorder that's characterized by compulsive drug seeking and use, in spite of adverse consequences. And addiction has physical as well as psychological dimensions. And as a clinician that's treating people who are addicted to drugs, it's going to be important to remember that both dimensions of addiction need to be managed effectively. Some people think of drug addiction as strictly physical, but drug addiction has both physical and psychological features. A diagnosis of addiction should only be made if 3 or more of the following have occurred simultaneously at some point during the previous year. A psychological withdrawal state when substance use has ceased or reduced, as evidenced by withdrawal syndrome for the substance, or use of the same or closely related substance with the intention of relieving or avoiding withdrawal symptoms. If there's evidence of tolerance, like increased doses of the psychoactive substance, and that's required in order to achieve the effects that were originally produced by the lower doses. Clear examples of this are going to be found in like alcohol and opiate addicted individuals who take daily doses sufficient to incapacitate or kill non-tolerant users, or a strong desire or sense of compulsion to take these substances. A third diagnostic criteria would be difficulties in controlling substance taking behavior in terms of its onset, termination, or level of use. Like, I said I was only going to drink one, but I ended up drinking 6. Or I said I was only going to drink tonight, I ended up drinking the whole weekend. Things like that. A fourth criteria would be progressive neglect of alternative pleasures or interests because of the psychoactive substance use. So, giving up important activities. Increased time or energy that's invested in obtaining the substance or in recovering from its use. So spending a lot of time using or going to get it or recovering from it, that would be another diagnostic criteria. Another one is persistence with the substance use despite any clear evidence of overtly harmful consequences, like harm to the liver because of excessive drinking, or depressive mood states that are consequent to periods of heavy substance use, or drug-related impairment or cognitive functioning. And of course, efforts should be made to determine that the user was actually or could be expected to be aware of the nature of the extent of the harm. Impairment of cognitive functioning, the first 2 criteria relate to physical addiction, while the remaining criteria relate to psychological addiction. And only 3 of these criteria simultaneously present in the previous 12 months are required to categorize an individual as having a substance use disorder. And the presence of one of the physical criteria is not required to categorize one as having an SUD. And the ICD-10 also describes harmful use as a pattern of psychoactive substance use that causes damage to one's health. And that damage may be physical, as in cases of like hepatitis from the self-administration of injected drugs, or mental, like episodes of depressive disorder that's caused by heavy consumption of alcohol. So the diagnosis requires the actual damage was caused to the mental or physical health of the user. So progressive neglect of alternative pleasures or interests because of the psychoactive substance use, like I said, increased time and energy invested in obtaining the substance or recovering from its use, and that persistent substance use despite clear evidence of harmful consequences. Often doctors and other healthcare professionals overestimate the importance of physical addiction in determining opioid addiction. But it is common in opioid substitution programs to look for evidence of opioid withdrawal and to estimate an individual's level of tolerance to assist in making that assessment of the appropriate dosage of the opioid substitute medication. So just note here that tolerance is defined as the level of increased dosage of a psychoactive substance that's required to achieve those effects that were originally produced by the lower doses of that same substance. So, for example, if a person's suffering from opioid withdrawal syndrome, a larger dose is going to be required to block the effects of withdrawal than previously required. So, opioid withdrawal and tolerance are definitely linked. It's going to be really important for us to understand the difference between the signs of opioid use or withdrawal and the symptoms of opioid use or withdrawal. The signs, or what you will see, is people withdrawing from heroin may experience from moderate to severe, but not life-threatening withdrawal syndrome. Signs and symptoms of heroin withdrawal may be mistaken for a bad dose of the flu. And heroin withdrawal is rarely fatal unless the person becomes dehydrated or they have coexisting serious medical conditions. But the onset and duration of withdrawal is going to vary according to the drug used. And the withdrawal symptoms from heroin can commence 6 to 24 hours after the last dose and can last for 5 to 7 days. Methadone withdrawal starts about 2 to 3 days after the last dose and lasts for up to 3 weeks. There may be prolonged withdrawal phases following an acute phase. And it's often associated with depression, and this can last for several months and is associated with a higher risk of relapse. The symptoms, what people complain about how they feel, is different from the signs. The signs are what we see. The symptoms are what they say they're feeling. So far we've covered some myths and facts about heroin addiction, and we've identified that not everyone who uses heroin becomes addicted, and discussed heroin withdrawal syndrome. And we've also looked at some of the physical elements of addiction, and we've discussed briefly the fact that addiction risk is related to the interaction between substance use and the environment in which it's used and the individual factors about the users. So we're going to look more closely at some of the individual biological factors, but when we're looking at opioid withdrawal, the signs are yawning, tears, dilated pupils, sweating, runny nose and sneezing, tremors, goosebumps, diarrhea, and vomiting. These are all the things that we can see. But the symptoms are going to be a loss of appetite and nausea, abdominal pain and cramping, hot and cold flushes, joint and muscle pain or twitching, poor sleep, cravings for the drug, or restlessness or anxiety, things that we can't see, but they feel. And we know that addiction involves the interaction of multiple factors that influence vulnerability and risk. And these are going to include biological, genetic factors, environmental factors, the type of drug, the brain chemistry. The interaction between these affects the brain in such a way that leads to an increased vulnerability to addiction. So there's 4 main ways that the addicted brain is different from the non-addictive brain. And we're going to look briefly at each in turn. So as I mentioned previously, drugs directly influence nerve cells by altering the number of sensitivity of receptors that switch on the nerve cell activity. And I'll talk about this more in detail shortly, but beyond a drug's effects on receptors, drugs also alter the brain's metabolic activity. There's many areas of the brain that have reduced metabolic activity following drug use. And continuous reduction in the nerve cell's ability to use glucose or energy is going to result in disruption of the many brain functionings. And the drug use also can affect an individual's responsiveness to environmental cues and genetic expression. Drugs can influence the genes in the nucleus of brain cells that are responsible for protein expression, which then in turn can influence an individual's cravings to use drugs. And the genetic risk of addiction is a topic of intense research. There's an 8-fold increase in the risk of addiction if a drug user also has a family member who suffered from addiction to the same drug. So basically you have a 50% chance or a higher risk of developing a substance use disorder if one of your parents did, and 25% risk of developing that substance use disorder if a grandparent had it. So in order to understand how drugs affect the brain, it's important to understand the reward or the mesolimbic pathway. And while there are other brain message systems that are affected by drugs, this one is of particular importance. The reward pathway involves several parts of the brain, some of which are highlighted in this slide. And this right here is a view of the brain kind of cut down the middle so we can see where this mesolimbic system is. An important part of the reward pathway is demonstrated in here, and the major structures are also highlighted, like the VTA, the ventral tegmental area, the nucleus accumbens, and also the prefrontal cortex. The VTA is connected to both the nucleus accumbens and the prefrontal cortex, and it sends information to these structures via nerve cells. The nerve cells of the VTA contain dopamine, which is then released into the nucleus accumbens and in the prefrontal cortex. And this pathway is activated by psychoactive drugs. The VTA and the nucleus accumbens are both in the midbrain, and they're responsible for motivation and learning and reinforcement. And they're activated by drugs. And the dopamine then sends the information from the VTA to the nucleus accumbens and then to the prefrontal cortex. The prefrontal cortex has influence on abstract thinking and planning and memories, and these actions influence the desire to use the drug. So the act of liking something is controlled by the forebrain. So if you have a pleasant reward from something, your reaction is to like it. But when you anticipate the reward and do things motivated by that anticipation, your brain has decided that you need it. So the act of needing something is a midbrain dopamine phenomenon. And we have basic biological needs like food and water and sex. And those are needs for survival. So drugs activate that same pathway and trick the brain into believing that drugs are necessary for survival. Food and water are essential for life. So when you have just had lunch and something to drink, the desire for food and water is not particularly high. But imagine if you refrained from eating well past 8 p.m. Your desire for food and water would likely be much different. Imagine now that you go 2 days without drinking and eating. A bottle of water will be far more important than anything else. The pathway in your brain that we just discussed helps you to prioritize how important things are and what you need to do to manage those priorities. So drugs have a way of influencing this pathway and tricking the brain into believing that they are essential for life. So if someone addicted to heroin didn't have his hit for 2 days, the hunger for the drug is going to be as intense as our hunger for food if we didn't eat for 2 days. However, although increases in the dopamine are important in reinforcing the effects of drugs, these increases alone don't adequately explain addiction. Drugs affect the brain in such a dramatic way that the brain tries to adapt. One way the brain adapts is to reduce the number of dopamine receptors on the nerve cells. Studies have shown that dopamine receptor availability is significantly decreased across the wide variety of types of drug addictions. And moreover, these decreases persist for 4 to 6 months after the last use. So when you are addicted, the nerve cells no longer operate in the same way. You can see in this slide the levels of dopamine aren't the same. The brain of a non-drug alcohol user is going to be different from the brains of individuals who are addicted. We see the differences here in the two pictures. You can see that there's much less dopamine in the brains of those who are addicted versus those who are not. So how does the reduction in dopamine receptors change the effects of drugs on dopamine? Well, drugs increase dopamine release from cells in ways that are both quantitatively and qualitatively greater than those from the natural stimulus. Increases in the dopamine release are 5 to 10 times greater from drugs than from the natural stimuli. And some drugs block the transporter that recycles dopamine back into the nerve cell. The net result is that following drug use, dopamine stays in the synapse for a longer period of time. So despite the fact that the number of dopamine receptors is decreased in a drug user, the probability of nerve transmission from a drug is very high, not only because the dopamine concentration is very large, but also because the dopamine remains in the synapse for longer. The drug user learns that natural stimuli no longer produce pleasure, but drugs do. And that's a fact that drives and motivates subsequent drug use behavior. And once you've been exposed to a stimulus, your motivation to repeat exposure to that stimulus is either going to be high or low, depending on how you respond to it. You may even predict what will happen if you are exposed to that stimulus again. Perhaps you felt good the first time you were exposed. You might predict that you're going to feel good the second time. So there's this incentive for you to be exposed again, feeling good. And drugs impair our judgment such that the incentive to obtain them is excessive. And drug users who are addicted make irrational decisions because this impaired judgment. They become highly motivated to obtain drugs and to use them. Almost no one becomes addicted the first time that they use a drug. Drug use, misuse, and addiction can be thought of as points along a continuum. Any use of a mind-altering drug that causes physical or psychological harm is drug use. But the point when drug use becomes drug addiction is often less clear to the drug user. Different drug users may reach the point of addiction at different times. People start and continue to use drugs due to recreation and experimentation, self-medication, social relationships, peer pressure, or just to improve their functionality. Addiction is a brain disease that makes it hard for the drug user to stop using drugs, and people who are addicted have difficulty controlling their use. They give priority to the drug use over other activities, and they experience withdrawal symptoms when they stop. They have strong cravings to use drugs, and they continue to use even when they're having problems, or use drugs to feel normal. It's going to be important to understand that the person who is addicted to the drug is going to need time to recover, and that addiction can be a chronic relapsing disorder. It's also important to note that addiction is not a brain disease alone, but it is influenced by the social context in which the addiction develops and is expressed. If we see addiction as a psychological illness with critical biological and behavioral and social contexts, the treatment strategies have to include biological, behavioral, and social context elements. Both the underlying brain disease and the behavioral and social cue components have to be addressed.